of the issues that are not as clear is that what is going to happen if we have this transformation, and that's why we are worried about it. We think that it's too fast. Now, when we talk about integration, a few things come into mind, right? When you want to integrate, you are going to use up that private fund, which is there. And I think that's a big attraction for this particular government to get everything on board, form a huge corporation, maybe another GLC-like thing, maybe even a crony company. I mean, that's a sad thing about it, because we've seen it happen too many times for us to look at that. And the number we're talking about for now is actually around 45 billion, right? Although we know it's around 30 to 35 billion on our national health accounts, just to give you the numbers. But it's closer towards 45 billion if you look at everything else together. And that's a huge amount of money, And I think if they were to just take off one, or God forbid, 10% or 15%, it's billions of dollars for a lot of very rich CEOs and managers. I think we all have to be very skeptical about this kind of change. So, and I think there's really not enough feedback. And then when it comes to the health financing scheme, the insurance, although it sounds good on paper, the great majority of the people who will suffer will be actually the one right at the ground. Not so much those who are middle class and those who are rich, because you are taxing them once more. And if you think you know about it, let me give you an example. I think I was attending a workshop with the EPF, talking about the employment, how much of money for retirement. And as you pointed out, there's so few people earning enough money. By that time they retire at 55, only about 40% has less than 50,000 ringgit in the bank, in the EPF. And that is from 55 or 56 until our longevity, which is now around 75, 76, about, or maybe a bit longer. So close to, say, 73, about 18 years to go living on 50,000 ringgit for you and your family, and your wife, for example. That's not enough. So EPF says, no, don't touch my money. You're talking about whether to get some money from here. Then we have the SOCSO, says we have even less money, don't come near us. So where do we get the money? So that's why they have to create a new fund. It's another poll tax based on the percentage. The figures, actually, you've heard about it, about 9.5, 9.6% is how they worked it out. Okay, because that is the amount of money. You take the total wages in the country, and then the amount that is spent on healthcare right now, and you divide it by the people who are earning, say that, I think about 7.7 wage earners. And then you work out a number, and this actually has been worked out by Subramaniam of Aliran. He works out that it is around 9.6 or 9.7%. And it will be around, that will be the median kind of income, that we need to put in. So with that amount of money, then it works out that maybe, okay, this is what the government wants. The government says you'll come up with 3%, and that other 7% or thereabouts will have to be taken care of by the employer or the employee, and you split the difference, for example. So the number that actually came out in one of the discussions was around 3.5, thereabouts, maybe 4%. Okay, but still it comes from you, okay, and that's important. And when it comes in, then the money goes into a pool, as you have pointed out. Okay, it sounds good on paper because then you're supposed to get all the benefits. But that's where we fear that you will not get the benefits, because there's going to be this limitation as how many times you can see, how many times you can be referred forwards, because there are penalties. And there's also what we call performance measures. If you do well, you keep the patients in your system, I'm going to reward you, rather than forward to referral for specialists and when you do need. So it may actually make the problem a bit worse. And I think we don't really have that. And this is actually the sort of form that they were putting. We are right now roughly in phase 1 to 2. This is what they tell you, right? In fact, they've been telling everybody we are close to a phase 2, but they're very far from that. Okay, and they want to work actually towards phase 4, which is by 2020. Okay, now I think the spanner has been thrown in the works. I think they will wait for a while until after the elections. And if they win, I think they're going to push it through. So we may have to stall that. So in theory, I think we all totally agree that it is actually a good plan to do something well. I just go back to Anurin Bevan, who is actually he's a liberal socialist, liberal Democrat. Yeah, not a socialist party, not a Labour party. And he was the minister at that time as a coalition government in 1948, just after the war. And he found that there was a lot of problems with health and soldiers coming back, a lot of veterans. So he says, look, And at that time, there were very few private centers. So he says, we're going to nationalize and have this system. And it's going to be different, a little bit different from the German system. The German system started about 100 over years ago, which is the Bismarckian system, where it is actually through national health insurance. Actually, it's far more developed. It's probably the most developed. Okay, you can read about that later on. But roughly, this is how it happened in England, and it has gone on quite well because it provided a service. But I think at this point in time, even the National Health Service in England is breaking down because there's too much of this put in market forces, which Margaret Thatcher actually brought about. It created a lot of tiers of managers, which actually increased costs rather than the other way around. Right? Every time you build in all these bureaucrats, you tend to cause costs to go up. So although in theory, I think we all accept this premise that is for equity, for solidarity, the reality is probably not quite there. Now, so that's why we coined this term. If it ain't broke, why change it now? We can have reforms, but I think the reforms must be progressive rather than a radical change right now, especially when there's so much of mistrust in the system. And I think this is very important, and we don't know what is the final plan at the end of the day. And in fact, WHO consultants, a few has come over, except for maybe the last one, that chap from Taiwan who did from Harvard, who says that we can transform straight away and follow the Taiwan system. But most of the others who came, and this actually came from, I think, from one Korean consultant, he said that actually, you're not too bad here, right? We attended this workshop, but you need more evidence to assess if the benefits of the reform justify the cost. It's going to cost a bit of money first to begin. And more analysis on the service delivery aspects of the reform. And in this country, the very sad part of it is that we have hardly any data on our health service. If you look around, I was shocked, when you type in for health systems and health finance systems in the region, Thailand has got far more information in all the established journals around the world than we. In fact, the two papers looking only at, say, the public sector and how well they're doing in the clinics, which is not good, not complementary, so they shelved. Only two papers. Then there are a few other things around the place. We have this really struggle to look for all this information. And I don't know why our universities are not looking to this. It should be. All universities should be doing it. In Thailand, the papers are published in all the Harvard, Mayo, you name it, WHO, World Bank. Just, if you don't believe me, just go and type in Thailand the sort of health reforms, and that's how they did it. And it's actually staggered over 30 years. It's not a perfect system. The 30 baht story is actually not quite right. It just means that you will have 30 baht, you pay upfront, you can go into a hospital, but it's at 3 ringgit to start. But then the government provides the rest of the funding. But nobody is denied. Okay, the waiting time will continue to be there. So he actually explained that maybe we should think about partial reform rather than all over it. That's why we are saying, why are we doing it so much? And then maybe we should pilot different components of the One Care proposal, which I think it makes sense. If you want to do it, why don't we do it with the public service, enhance all the public service better? Put more money inside, raise the standards, make sure that it works, make sure that maybe all the civil servants will be taken care of only in the public sector by contributing that so-called 3 or even that 10% that you talk about. The government provides it. And then see what happens in the system. Is it efficient? Is it productive enough? And this is what we are saying. And if it's not productive, don't make the entire system break down just because you're going to take over the whole system. And I think that's a very frightening prospect. Anyway, just to tell you how well we are doing is that this is taken from WHO, and we're actually doing quite well. I think a lot of people think that 88% think that our system actually is not too bad right now. Okay, and this is from a 2006 paper, Working Together for Health, from WHO report, the World Health Report. So we're not doing badly, the way I see it, okay? But of course I'm biased from the point of view from the professional. In terms of having critical shortages for nurses and all that, we have been telling the government we are not bad, really. We're just like everyone else except for those darker areas where there's a critical shortage. But they said, no, we're going to flood the market with nurses. Now we have about 12,000 nurses who have got no jobs. When I put up an advertisement, the SRNs from all the funny little colleges came. And every time I put up a notice, they do stay long. 30 to 80 will call up, to get the $1,000 to $1,200 job because they can't get jobs anywhere. And this group has been going around the whole country. So it's actually tough. And now doctors, we've been telling them they're just producing too many. But they said, no, you know, we want to have 1:400 by 2020. So now we have a real problem. I think today you read the New Straits Times. One of my colleagues actually wrote another paper in a Berita, which is quoted by the New Straits Times, telling that we are producing too many. Again, and I think I was a bit surprised NSC actually supported that stand, that we have too many. So we don't really have critical shortages about this. And for the amount of money that we are actually spending, we actually do very well. You know, if you look at the rest of the world, we spend really very little money, and yet, you know, we can reduce our under 5 mortality. Yes, of course, when we talk about the rural health and all that, they don't get the best that we can have. You know, if you have a heart attack, you know, you have people in the kampungs that probably die before they get to a nearest facility and thereabouts. I mean, that's true. But if you're talking about longevity and expectancy at life, we are right up there, you know, for the amount of money that we are spending, which is nothing compared to, say, USA, which is right at the top there. You know, so we're spending so little money. So if we actually enhance that little bit, we are paying about 2% to 2.2% on from the government. Again, just to show you another perspective, 2005, we spent not too much money, about 500 to 1,000. Actually, it's less than that, but this is in real dollars. So we probably spend around 250 to 300 to 500 ringgit here, and we are actually getting about 70 odd. So let me just take you through the system. This is very complicated. Okay, in a way that is true. The health ministry is a mess. Okay, and there are lots of people who sit around and do not much. I mean, that's the reality. Okay, now that is the hardest thing that we can do, to tell them that, look, you know, you have to do better than that. You talk about minimum wage. Why a lot of employers very unhappy to give them minimum wages? Because a lot of hangers-on cannot be sacked. All right, you're worried about the corporatization system. They are also worried, because I think it will not come true, because they are also worried that if they are going to put efficiency into the system, then a lot of them may lose their jobs. And who's going to be responsible? I mean, the government cannot be giving out the BR1M for everybody. How many times can you do that? Huh? Bring 500 for everybody who's no job? You can't do that, you know, and there's no money, there's no systematic way of doling out money like that. So right now, this is the scenario we are facing. Outpatients, okay, you say that the cost is going up. It is up, but I think you must see it in the context of the region. So that part I disagree with you, Kumar. I think it is going up, but we are still actually far more favorable for our earning capacity compared to, say, Thailand in the private practice, or in Indonesia, for example. Singapore is another different case altogether. Vietnam, for example, is actually more expensive in the private sector than we have. But nevertheless, it's not cheap, okay? But it's moderate. And if you say it's expensive, especially for the GPs and the outpatients, 65 million patient doctors, and this is around the same now, about 62 to 60% of the public still goes to the private sector first. And that is not change, you know, because they must be doing something right. I mean, who wants to pay 25 to 40 ringgit to see a doctor outside, rather than pay 1 ringgit and then get, you know, and wait, of course, half a day or 1 day to see a government doctor, you know? But obviously there must be something right. And this is where we disagree with the ministry. The ministry says, oh, the GPs are seeing them for too short, and they don't spend enough time. They over-treat sometimes, they under-treat, they miss this chronic disease management. Say, for example, if I have diabetes, they don't treat me well enough. So we said, okay, show us that we have done so badly. Then they said, okay, look at our National Health and Mobility Survey. Our diabetic rate has gone up from 10 years ago. I think 1996 was about 7-8%. 2006, the latest one, was 14.9%. Therefore, you all are not doing their job. I mean, this is nonsense. That's not the real reason. The real reason is that Malaysians have become big consumers of you know, Western food, and become totally sedentary, and that's the whole region, you know, and that's the problem. But again, you know, how to tell them that, you know, but hypertension has come up, you know, about 42% now of the population. Yeah, it's a big problem. So they say we are not doing well enough. So we say, okay, let's take a look at what are you doing in the public sector, and that's where they keep very quiet. If you go to a MOPD or a FOPD, right, a female and a male, who do you see? Do you have continuity of care? Zero. Every time you walk into a clinic where you share with about 3 doctors and 3 patients who sit right in front of you with no privacy, the doctor is busy writing down the next prescription